Hello, everyone. We're going to start in a few minutes. As everyone is coming in, we'll be starting shortly. Hi, everyone. Thank you for joining the Ask the Expert panel. We're seeing a number of people join, so we're going to wait one more minute and then we'll get started with Dr. Isakoff. Okay, great. I think we're ready to start. I see a number of people that have joined us. So hello, everyone. Thank you for joining another Outcomes4Me webinar in our Ask the Expert series. Today, we are delighted to welcome breast oncologist, Dr. Steve Isakoff from Massachusetts General Hospital here in Boston. Dr. Steve Isakoff is the Associate Director for Clinical Research at the Mass General Cancer Center and the Director of Breast Cancer Clinical Research in Mass General Breast Cancer Program and an Assistant Professor of Medicine at Harvard Medical School. Dr. Isakoff is joining us to talk about America reopening, the strategies hospitals are taking, and the precautionary steps breast cancer patients need to take as America and the world go into the next phase of reopening. My name is Maya Saeed, and I'm the co-founder and CEO of Outcomes4Me. Outcomes4Me wants to help and empower breast cancer patients with the tools and resources to better navigate their care. Through our mobile app, patients can have access to free resources and information, including treatments, clinical trials to help them manage their disease. The format of today's discussion will be one part discussion and one part Q&A. We have gotten a number of questions from our users prior to this webinar, but we do encourage everyone to send us questions via Zoom or Facebook Live, and we will do our best to get them answered during our time together. Just as a reminder, we ask you to ask questions general in nature, as Dr. Isakoff is not able to offer medical advice about your individual case. And we would remind you to follow up with your healthcare team for specific recommendations for your care. I do want to start this off by allowing Dr. Isakoff to give a brief introduction about himself, and then we'll jump right into answering your questions. Please, Dr. Isakoff.
Thank you, Maya, and thank you very much for the invitation to be with you for Outcomes4Me today. So just a very brief introduction. As Maya said, my name is Steve Isakoff. I'm a medical oncologist and breast cancer specialist at Mass General Hospital in Boston. I've been at Mass General for about 15 years now. And our hospital, as many people know, is in Boston, has been one of the larger sites experiencing COVID cases. And so we've had a fair amount of experience, obviously managing COVID cases, but also managing breast cancer during this unprecedented pandemic. And I've also had the opportunity through my participation in the National Comprehensive Cancer Network to be a member of a consortium that was involved in developing some guidelines for managing breast cancer care during the pandemic that was recently published about a month ago in Breast Cancer Research and Treatment, to try and give some guidance to our fellow breast cancer specialists given the changes that were occurring during the pandemic in our ability to deliver care. So I'll stop there, and I look forward to a discussion about as we're hopefully emerging from this pandemic, and take any additional questions that anybody might have.
Thank you, doctor. So, I mean, obviously there is one question on everybody's mind, whether, having breast cancer or not, is, can I go back to work once America reopens? So I guess the question, let's start there, as somebody with a history of breast cancer or, in active treatment, can we go back to work?
Yeah, so that's a very good question, and a very somewhat broad question with lots of answers. So obviously the whole country is eager to get back to work. And patients with cancer, and in particular patients with breast cancer, our topic today, do have certain things that I think need to be taken into consideration. The first thing I would say is, even with the reopening of the country and going back to work, individual companies and people are really going to need to still follow a lot of guidelines. And I think we've learned quite a bit in the last few months in managing this, but we've really learned that the protective approaches that we've been recommending do seem to work. And in general, those are things like wearing a mask, certainly when you're in public, frequent hand washing being better than hand sanitizer, but both being effective. Maintaining physical distancing, and I've tried to make it a point to call it physical distancing and not social distancing, as our hospital president had done early on in this, because obviously in many ways this is a time when we want to maintain social contacts as much as possible when people are feeling isolated, but it's really physical distancing that we want to be careful about. And then the fourth piece of that is monitoring. It means if you're feeling unwell, if you have a new cough, or if you have a sore throat, it means not going into work. And likewise, it means that the people that you work with need to feel the same impulse and responsibility that if they're not feeling well, they should not be coming into work. And there was actually a wonderful piece in the New Yorker a few weeks ago by Atul Gawande, who some people may know, who's a surgeon at Brigham and Women's Hospital, but is also a public health expert, and had worked in government in the years before he became a surgeon, and a frequent writer for the New Yorker. And he wrote a piece about, if people want to get reopen the country and get back to work, that a blueprint for that can actually be found from hospitals. We've been following these four approaches, and actually have very low rates of in-hospital transmission in terms of healthcare workers getting infected or patient-to-patient infection. And I think if we can continue those approaches as we move back into opening the country, people going back to work, people being out shopping, then I think we'll be able to manage this. And so in terms of individual people going back to work, I think for an individual, there's a certain risk-benefit assessment. And so if you are currently undergoing active treatment with chemotherapy, for example, where you may be more immunosuppressed, it may not be the best idea to be going back to work and surrounding yourself with other people. But if you're later on in your course and you've had breast cancer in years past, then I think it's less of an increased risk in terms of having had breast cancer. And so I think, the large answer is, in general, with careful behavior, going back to work could be okay. My concern, quite honestly, is that many people just out in the community are interpreting sort of reopening of the country as we're past this pandemic. And my concern is that there'll be a certain amount of both fatigue from the pandemic, but also a sense of everything's okay. And I worry about the larger community potentially not following all of these recommendations. And so I think if you can be sure that you're working with and among people and places where these restrictions and recommendations for safe behavior can be followed, then it's probably pretty low. But if you are going to be putting yourself in an environment where you're likely to be exposing yourself to people in the surrounding environment and community who are not going to be following these guidelines, then I think there's certainly an increased risk of contracting that. And it's the only other point I want to make before we move on to the next question is that we have been in many ways largely successful in flattening this curve. And when I talk to colleagues around the country, in New York and New Jersey, Washington State, Massachusetts, we've had a lot of cases. Our cases are fortunately on their way down. There are many places in the country now, many rural places in particular, where they're actually seeing the rates still going up. And although we've been largely successful flattening the curve to a certain degree, in terms of, outside of some very high hotspots like New York, what we worry about in the healthcare community is that this is not going away in the very near future, and that these management strategies for safely going back to work, they're not going to end July 1st. We expect as things loosen up that we're going to be seeing pockets of hotspots. We hope we don't see a general rise, but we're all sort of very worried about that. So with diligence and caution, it's not unreasonable to consider going back to work. And then one other point I want to make too is obviously following along with all of your obviously local, state, and federal restrictions. And so, for example, in Massachusetts, we just had our governor come out with a blueprint for reopening and for people going back to work. But it involves a very stepwise approach where offices can't increase by more than 25% of personnel. And really every governor in every state is coming out with some blueprint. And so obviously the going back to work should be in accordance with your local government regulations and federal recommendations as well.
Great, thank you. And just, because we've had a number of questions in the past around, people that essentially whose work is in the healthcare space. So in other words, whether it's healthcare workers, nurses, nurse practitioners, doctors that have a personal history of breast cancer, would you say anything differently in terms of reopening, or just kind of, the same guidance that you just shared?
Yeah, so I think in the beginning, before we, when we had severe personal protective equipment shortages, when we didn't quite understand how important all of this safe behavior really was, we certainly did see, and unfortunately, for example, in New York and in Washington and even in China, there have been, cases of frontline healthcare workers getting ill very early. I would say, 8 or 9 weeks into this now, the situation is very different. We are really not seeing frontline healthcare workers getting in-hospital work-related transmission to any significant degree. And most of the cases that are being looked at with contact tracing, actually healthcare workers that are getting tested positive, more often than not, it's because of community exposure from home and another person in close confines with them who's working in another place. And so I think, again, if you are on active treatment and you are immunosuppressed, I think the risk-benefit ratio may be a little bit higher in favor of potentially not putting yourself on the front line. But that being said, I myself have spent time on our COVID service, and it really is quite impressive that with the proper approaches and techniques, people are generally safe. So So I think some of us are saying now that there's in some ways no safer place to be than in some of these big hospitals now, because of the healthcare professionals are really being incredibly diligent following these recommendations and keeping the spaces really quite clean and safe for patients, but also for our fellow coworkers.
Great, thank you. Another major topic on everybody's mind is, as you know, through this crisis, a lot of the elective surgeries, a lot of the screening, mammograms have been postponed or canceled. So my question is, as regions around the country open, and also taking into account that they're opening in different phases and kind of approaches, how is that impacting, what are breast cancer doctors and hospitals how are they approaching this? And what are some of the main things patients with breast cancer should know, both in terms of how hospitals are opening up and whether or not, they're open for screening, for elective surgery, for, reconstructive surgery in the context of breast cancer treatment?
Sure. So that's a great question. So, for example, in Massachusetts, along with many other states, in sort of mid-March, we received an order from the Department of Public Health. All non-essential or non-emergency surgeries had to stop, and we literally had patients who had their breast cancer surgery scheduled for a day or two later, and that had to be postponed. And in general across the country, I've heard this from a number of colleagues that they had very similar situations. But as you noted, we're all sort of emerging from this at slightly different phases. Some places are approaching their peak, but many places were able to flatten the curve, and we're all eager to get back to these surgeries and other procedures for breast cancer patients in particular. And so, for example, in our institution at our satellites, we were able to just recently open up operating rooms again to help take care of all the breast cancer surgeries that were deferred for some time. And really, over the period of about 2 weeks, our breast surgeons were able to sort of catch up. So the first thing that I want to assure people, and we're a little bit late into this, but the first thing I want to assure people is when we deferred those surgeries, it was done very thoughtfully and in a way, and this was part of the guideline or recommendation committee that I was a part of, it was done in a way that really was intended to not compromise patients' long-term outcome. And so for those, for example, with estrogen-positive breast cancer, we didn't just say you can't have surgery for 3 months. We put people on preoperative anti-estrogen therapy, where we actually have a lot of high-quality data showing that that's a very effective approach. It in general keeps people safe. It can help shrink the tumor. For other types of breast cancer, we can give preoperative chemotherapy if necessary to sort of delay the surgery. And those patients who truly, from the medical perspective, had an urgent need for surgery, we were generally able to make a case and get that, at least in this country. I'm not sure about in certain parts of Italy and other places that were highly hit. But along with that, as you were noting, in many places around the country, things like screening mammograms were shut down. And again, it's important to note that in the United States, we generally recommend annual mammograms, but in most of Europe, they actually recommend every 2-year mammograms. And so a delay of a few months of having your annual mammogram is generally not thought to have a significant deleterious or negative effect on your outcome. And obviously, if you felt a lump, we were providing care for patients who had a problem. It was really just those screening tests. Now, in terms of opening up, again, we're sort of, and I think most hospitals around the country need to do this in a very coordinated fashion, taking a lot of different things into account. Things like what is your governor mandating locally? And so in Massachusetts, our governor came out on this past Monday with a blueprint for reopening, and among that, high-risk screening, so patients who, as they defined it, were beyond 2 years from their mammogram or had a BRCA mutation or high risk is how we're interpreting it. we're now able to open up. But routine screening for patients that have had a mammogram within the last 2 years is still on hold. And it's not to be cruel to patients, it's really actually for the safety of everyone. And the reason is we need to come up with procedures now, for example, where we can't have a full waiting room of, people sitting shoulder to shoulder waiting for their mammogram. We need to come up with procedures to minimize the number of people coming in contact with each other, maintain physical distancing, and really follow all of those guidelines that I've said have been working so well. And so we're slowly starting to do that. We envision, for example, in Massachusetts, as we enter phase 2 of our opening, which according to the governor, hopefully will be within about 3 weeks. We hope to start seeing the routine screening mammogram coming back. And I, that's going to be the case really around the country. But the key point is we want to do this in a way that's safe for the patients and that follows our local regulations. But I think we're moving in that direction, and I think hospitals are open for business for people who need urgent care, and we're slowly coming back for more of the screening care and care that can be deferred a little bit longer.
Great, thank you. And actually, along those lines, so let's say somebody is scheduled for surgery now. Is there any potential risk for patients to get surgery in the hospital as we enter the next phase of the pandemic?
Yeah, so that's a great question, and it's a message that myself and my hospital and hospitals across the country really want to get the message out. If you need care, come and get it. We've all heard stories at our hospital in New York, patients having chest pain, not coming in and having heart attacks and strokes, and hospitals are open and we are keeping things safe. So for your breast cancer, for example, we are now doing our surgeries because our main campus operating rooms are not yet at full capacity, but our satellite operating rooms are. And so, there's procedures in place. People are getting screened the day before with phone calls. Are you having any new symptoms, new fevers, new cough? And everyone's, following hand sanitizing and masking. So the answer is yes, hospitals are safe if you need your surgery. If it's time, if they can get you on the operating room schedule, we encourage you to go forward with that and get that taken care of so you can go move on to the next phase of your treatment.
Great, thank you. Related to this, and actually we did get, this is a question related to this theme, we got a question that was submitted before the webinar around a person that essentially had her surgery postponed. The surgery is coming up actually in June. And the question is around recommendation for going to follow-up appointments and chemoradiation treatments.
Yeah, so great question. So regarding, I'll mention the follow-up appointments in general first, and then we'll talk about the chemoradiation. So follow-up appointments, one of the I would say positive things that have emerged from this pandemic is we've spent years trying to figure out how to do virtual visits, and literally overnight we figured out how to do it. Just like we're on a Zoom webinar now, we now have Zoom embedded into our electronic record system. We happen to use Epic and it's embedded, but most medical record systems are doing that now. We have converted about I would say 60% of our visits are now virtual. The ones that are in person are generally patients undergoing chemotherapy or having an issue that they need a physical exam. But almost all of our routine follow-up visits, in terms of 6-month or 1-year follow-ups, many of our post-surgical visits now, our surgeons are doing a lot of virtual post-op visits. Again, as long as there's no problem. If the patient's having a problem, they certainly encourage, again, we're open, we're safe, we're just trying to limit patient volume and patient flow to maintain distancing. But and so I would say if you're doing well and you're offered a virtual visit, that is, we're finding patients are really liking that. It's saving driving into the hospital, it's saving parking, you're in the comfort of your own home. To be perfectly honest, we're finding people tend to run on time better by doing virtual visits because your questions and your action is addressed. You're not waiting for the medical assistant in the room. But again, if you need to come in, come in. As far as chemotherapy and radiation, so during the peak of the pandemic, and again, this will be at different phases around the country. Many centers fortunately had very low rates of COVID admissions, and certainly outpatient facilities are seeing this much less. But in many cases, we did have to defer radiation a little bit because we were just trying to preserve our protective equipment and all that. I think most places now, our radiation department is really, operating at near capacity now. The big issue is more having the staff to come in and just making sure that we don't have too much staff in one place and that we're in compliance with regulations. But in terms of patient care, they've worked out really good procedures where we're not having people wait in the waiting room. We're having them come in when it's their time to go into the radiation machines. And in general, I would say, our radiation team is generally doing a virtual consult to start, but then meeting you when you come in for your planning, and I would encourage that. Chemotherapy is actually somewhat similar. So obviously, chemotherapy can be immunosuppressive, and it's something that we weigh as we're weighing the risk and benefit of treatment. In general, we've come out with some recommendations, and what's been interesting as I talk to people around the country, we put out these consortium guidelines or recommendations about a month ago. As I talked to people around the country, many people had sort of come up with essentially the same recommendations internally at each hospital, because I think there's sort of certain natural things that make sense. And so in general, we've been using growth factor support to try and help keep the white blood cell count higher. We always use it with certain chemotherapies. We're a little bit more liberal with that. When we have a choice of regimens, some require weekly visits to the hospital, some every 2 or 3 weeks. During the peak, we've often elected to try and minimize visits. But what I guess the big message that I want to send, though, is if you need chemotherapy, if that's what's recommended, we can deliver that in a safe way. Our infusion rooms, for example, are following the recommended guidelines. They're keeping patients separated by the right distance. We're masking patients for now. We and many other hospitals still have a no visitor policy. And while that's been difficult, really for many patients coming for infusions, we've made a big effort through these virtual visits that if I'm seeing somebody in person and we want a family member to be involved, we're just getting them on the phone. But by keeping the no visitor policy, we're again minimizing the risk of transmission and not overwhelming the number of people who are coming in through the doors. So chemotherapy, radiation can be delivered safely. Chemotherapy can be immunosuppressive or is immunosuppressive, but again, if you're following all the recommendations, we think it can be with minimal risk. And radiation is generally not considered to be significantly immunosuppressive, although it does require daily trips to the hospital. In general, this is being done in a very safe fashion, and I'm honestly not aware of any cases of patient acquisition of COVID from our radiation department. There have certainly been some cases where a staff member or a patient may have turned out to be found to be positive, and so they do contact tracing and tell patients, we should just monitor, but I actually haven't heard of any cases of patient-acquired transmission during radiation or during their chemo treatments.
Okay, great, thank you. We have received a number of questions via the live feed. Please feel free to continue asking questions, whether on Zoom or Facebook. So the questions we've got are, I'm going to group them in a couple themes, and actually some of them cross themes of questions we received prior to the webinar. The first one is just to pick up on the theme we're on, which is, clearly the message around chemo and radiation, is very clear. There's been a number of questions around, other types of treatment and whether people could go back to work or not, or kind of, how they should address them. So, just to bucket them a little bit, one question that came up just now is a person obviously, diagnosed with invasive breast cancer, having gone through surgery and radiation, is now on, one of the drugs. So in this case, it's Arimidex daily. Is that, in which category is it, this drug? Is that something that, they should worry about or not?
So that's a great question to springboard sort of into just a quick summary of that. So I think many people on this call, if they've experienced breast cancer, know that there's several categories of treatment. We have anti-estrogen therapy, which are things like the aromatase inhibitors like Arimidex and Femara. We have tamoxifen as well, which is an anti-estrogen. We have things that are used in the advanced setting as well, like fulvestrant, that are all in the anti-estrogen category. We have standard traditional chemotherapy that many people know, things like adriamycin, Cytoxan, Taxol, Taxotere. We have biologic or targeted therapies, things like Herceptin and Protusomab. And then we have other targeted therapies, things like CDK4/6 inhibitors, things like palbociclib, abemaciclib, or ribociclib. We have PI3 kinase pathway inhibitors like alpelisib and everolimus. And so it's important to know that the anti-estrogen therapies for early stage patients are often given for a minimum of 5 years, often 10 years. As a group, Arimidex, tamoxifen, those drugs are not considered immunosuppressive at all. And when you hear things in the news or in publications, patients being treated for breast cancer are at higher risk. Well, you have to go a little deeper. And patients who are on just anti-estrogen therapy, you're 2-3 years out. No, we don't consider that to be putting you at any higher risk. Things like Herceptin and Protusomab, while it's listed in the side effects that you can have slight decrease in your white blood cell count, in general, we tend not to think of those as immunosuppressive, and so I wouldn't put any extra concern if you're on those drugs. And we usually give those drugs for a year in the early stage setting, and people with advanced disease could be on that long term. The standard chemotherapies, those definitely are immunosuppressive. Those can decrease your white blood cell count, which is important for fighting off infections. And so there's really been actually very little published data, and some of it's coming from China, but very little published data on outcomes of patients with cancer who then get COVID-19. And in the minimal reports that we have, very few of those patients were actually breast cancer patients. But in general, it makes sense that those drugs that are immunosuppressive, should you contract COVID-19, are potentially putting you at risk for higher complications. And interestingly, may blunt your own body's immune response to the virus. And so there's been some evidence that your ability to make antibodies might be lower if you're on those immunosuppressive traditional drugs. And then also the last class, those targeted therapies that are used in the advanced setting, the abemaciclib, ribociclib, palbociclib, alpelisib, those actually we do consider to also be immunosuppressive, even though they're oral and even though they're not traditional chemotherapy. We do consider those potentially increasing the risk of complications. Now, those drugs are typically only used in the advanced setting. They're only approved in the advanced setting now. And having advanced breast cancer by itself, and really any advanced cancer, may in and of itself be a risk factor for complications. Just by having an underlying cancer, we do think that contributes a little bit of immunosuppression. And then also, obviously, if you have any involvement in your lungs, since viral pneumonia has been one of the most prominent features of complications from COVID-19, that would be a little bit of a risk. So I think that kind of gives a broad answer, but Arimidex, the specific prompting of that question, you're okay.
That's very helpful. I'm going to come back to Arimidex in a second because there was a follow-up question. But before that, I do want to bounce back on something you implied, but now make it more explicit because it's came up also as a question. So going back to the CDK4/6. So in this case, the person that asked the question is taking Ibrance. And so one of the CDK4/6, essentially it's a recurrence, it's metastatic. So the couple of things you kind of touch upon, I'm not going to read the full questions as is because it's pretty detailed, but hopefully the person that we're answering the question will recognize the question. So, after had the recurrence, it's metastatic with a brain lesion, doing very well on the eyebrows, stable. The person says that her blood count does go down every now and then, but the question is there any reason for her to not work? As the nature of work that they do is taking orders by phone and curbside pickup, and so the question is there any reason that that person cannot go back to work with a mask, social distancing, the whole protocol?
Yeah, so I think these are tough questions. So the first thing I would say is, as part of the sort of guideline recommendations that our consortium came up with for people newly starting on these targeted therapies, there's some data that using a slightly lower dose to start may be just as good. And so one of the recommendations we had, and again, this is for sort of newly starting patients, was that it's not unreasonable to either delay starting the targeted therapy and maybe just start with the aromatase inhibitor and wait until the peak is passed and we're starting to open up, which is really the phase we're moving into now, to sort of minimize the risk of, as the questioner noted, low blood counts. But in somebody who's on it, usually once you sort of establish what your pattern is after the first few months of being on these drugs, you sort of know, at 2 weeks, my white count is X, and by 4 weeks, it's back up to Y. And so if it's been somewhat predictable like that, and when you're at your nadir, if your job really involves minimal interaction with other people and you can follow these procedures, again, it's hard to say in a specific individual person because you might have other conditions if you have underlying asthma, diabetes, if you have lung metastases. But as a general rule, I don't think it's unreasonable to consider that if you're following your local regulations and obviously working with your local physician. What I do tell patients, and what I've told my patients, is if you do come down with COVID, if you do find out you're infected, I would generally recommend stopping the targeted therapy. And quite honestly, I've been telling my patients, if you develop symptoms, and it might take a day or two before you can get sent in for testing, but if you do start to notice a runny nose or a sore throat or a cough or shortness of breath or a fever, I've been telling my patients it's probably a reasonable, it's not likely to make any negative impact on your breast cancer, but it's probably reasonable to stop your Ibrance until at least you talk to your healthcare provider, but sort of give your body's immune system as much of a head start as possible on catching up and letting that white count recover. And then depending on the state of testing in your area and potentially you can get checked. So that's kind of what I've been doing, is sort of a balance of, understanding people need to go back to work or might just get exposed even in their home environment. But also, we're on these medications as a sort of reasonable risk-benefit balance.
Great, and to pick up on the immune system, we had a specific question, but it's a more broader system around, is there anything somebody could do to, or would you recommend anything to boost the immunity? So, the specific question we got is around somebody actually undergoing daily radiation, and essentially they want to try to be healthy. They said, as an example, they're taking a few vitamin C a day, but is there anything that people could do to boost their immune system?
Yeah, so this is a question we in breast cancer get a lot, even outside of COVID, is what else can you do to boost your immune system? And it's been a question asked for many, many years, but it has come up even more in the last few years as we've now have immunotherapy, and we sort of recognize that by helping your immune system with some of these checkpoint inhibitor drugs, some that are now approved in breast cancer, that we can sort of train or help your immune system fight cancer. So it's coming up even more now. My answer to that is generally, there's really nothing proven that we know. There's a lot of claims by herbal supplements, and my general approach is, sort of normal recommended daily dose of vitamins is reasonable, but I usually don't recommend taking high doses of things. I don't think there's really any sufficient evidence showing that we know that these things, boost the immune system, and that word "boost the immune system" is really unclear what we really even mean by that. What I would say is for patients undergoing radiation therapy, I would definitely make sure to talk to your radiation oncologist about supplements, and in particular about antioxidant vitamins, because sometimes, and again, there's not great data on this, but some radiation oncologists do recommend avoiding high doses of antioxidants because during the radiation therapy itself, there's a theoretical question about, does that protect any cancer cells as an antioxidant? I'm not sure that there's good evidence for that, but I would just encourage people to talk to their radiation team about any supplements that they're taking. My general recommendation to my patients is the things that we know that are probably best for your immune system is getting the right amount of sleep and eating the right foods. And that's going to be the right recommendation just for breast cancer in general and just for your health in general. And, again, outside of COVID, my general advice about things like that are, for early stage patients, if we're successful and you're successful in not having this cancer come back, then you get to live to be, much older. And the next leading problem for women is heart disease. And the things that are good for your heart are also good for your immune system and good for your breast cancer, which is, eating well, exercise, and healthy diet. So that's probably what I would encourage, those three things, more than I would supplements or other things like that.
Okay, great, thank you. We're getting a few questions on Facebook and also on Zoom, so I just want to cover them under a theme. So one, you mentioned, kind of if people feel the symptoms of COVID, what they should do. We got a number of questions and, on specific drugs that actually, how do you distinguish between side effects of the specific drug versus symptoms of potentially flu? So an example of a question we got is going back to Arimidex, which caused some pain to joints and bone. And the question of that person is, how do you determine if this is medication-related aches and pains versus flu-like symptoms that you need to worry about in the broader context?
So this is actually a great and practical question that we face literally every day. And the reason is every patient that's coming into a visit to our hospital is getting screened the day before. Do you have any new symptoms? And what we're finding is, and this isn't just breast cancer, but we certainly see it in breast cancer, almost all of our patients who are going to be coming in because they're on chemotherapy or they're on a treatment have symptoms. And so it actually is not trivial to know if somebody says, yeah, I'm having, body aches and muscle aches, for our screeners, that's a flag. And they're going to call us and say, the patient's having these symptoms. So in the early part of the pandemic at our hospital, this was a big issue because everybody was reporting symptoms like this. And they made a simple modification to the screening, which is adding the word new. Do you have a new cough? Do you have new runny nose? Do you have new body aches? A new fever? And so I think, so one part of the answer to that question is, most people who are on drugs like Arimidex, on the aromatase inhibitors, if they're going to develop symptoms, they usually develop within the first few months. And they usually, hot flashes can improve over the course of a few years, a few months or so, 2 years. But the muscle aches or the joint aches usually kind of stick around. And so if you're having those kind of symptoms and you've just had them for months or years, then I wouldn't worry so much. If it's new, if you've been on this drug for 2 years, and now you have new body aches or joint aches or muscle aches, and you haven't had that before, then that might raise a flag a little bit more about, well, this is different. If you've never had hot flashes from these and now you're feeling warm, take your temperature and be sure. So it's not trivial. In this sort of non-COVID world, for patients who are asking, are my body aches due to this? A very common approach that many of us will take is we'll just tell you, just hold your Arimidex for a month or two and let's just see if those symptoms improve. And then we'll have you restart it. And if the symptoms come back, then you can sort of make the connection that, by doing that little mini experiment, that it's due to that. But I would say, in more direct answer to the question, it's really going to be the time course of the development of these. If it's new, then that, and it's different than what you've experienced on these drugs before, then I would raise the question. But if it's consistent with what you've been having and you're not feeling anything else, then it's probably just the same thing.
Okay, great, thank you. I do want to go through some of the questions we got through Facebook. So one of the questions is somebody that has stage 3 breast cancer, have undergone chemo, radiation, and surgery, and they tried 2 different medications that had horrible side effects. So, right now their doctor is recommending a shot to stop her ovaries from producing estrogen. The question is that a safe choice?
Yeah. So again, without knowing the specifics of the case, the fact that you're talking about the injectable medicine, it's probably a GnRH analog like Lupron, which implies that there's a hormone receptor positive or estrogen positive breast cancer. And it also implies that the person is premenopausal. And so in the setting of premenopausal hormone receptor positive breast cancer, in general, depending on the risk of the cancer, but for more than minimal risk cancers, usually giving you what we call ovarian suppression or that injection along with either an aromatase inhibitor or tamoxifen is considered the more effective of the options. And so we do try and do that. However, we completely recognize that taking an otherwise, premenopausal woman and sort of overnight turning them into a postmenopausal woman, it does come with a lot of side effects, things like significant hot flashes. It can come with sexual dysfunction and vaginal dryness. It can come with some weight changes, due to metabolism changes, and obviously the joint aches we've talked about. And so what I would suggest is, again, in discussions with your primary provider about how risky your cancer is and how much extra gain you're getting with those, in general, those are considered safe. Certainly in the COVID era, those are considered safe. Those are not immunosuppressive. To minimize visits to the hospital, as part of our recommendations, traditionally those injections have been given monthly. We've actually recommended and essentially have converted all of our patients, except for those who really don't want to, but we've converted all of our patients to the 3-month version of that dose, which really minimizes trips to the hospital, which both reduces contact with people, but also helps not take up our infusion room and patient flow. And so that is an option. If you want to, if the question is about safety because of coming to the hospital every month, that's one alternative. We've also been having a number of patients learn how to do this at home. And we've been working with trying to establish through visiting nursing facilities doing this at home. A number of my patients who live far away and can't come all the way into Boston, we've collaborated with their local primary care doctor's office or their gynecology office, where we have the Lupron sent to their house. They bring it to their local doctor's office and get the injection there by their nurse there. So I guess if the question was safety kind of in one or two ways, if it was safety as a drug, yes, it's safe. It's not immunosuppressive. If it's safety in terms of coming to the hospital, there are ways that we can minimize those visits.
Great, thank you. Another question through Facebook. So what about complications that came up during chemo, such as pulmonary embolism? Would that put a survivor at higher risk for complications from COVID?
So if it's a recent pulmonary embolism and it's still resulting in some shortness of breath, I would say possibly. We've noticed with COVID, one of the features of COVID that's been well documented now is a higher risk of blood clots. Now, somebody who's just recently had a blood clot is probably also on anticoagulation, usually for a minimum of 6 months. And if it's an advanced disease patient, advanced or metastatic breast cancer, often it's lifelong. Theoretically, being on that blood thinner should, in some ways, help protect against developing additional blood clots should you contract COVID-19. If it's a history of a blood clot or a pulmonary embolus that you've had in years past and you've recovered from it, it was attached to, while you're undergoing treatment, but you've recovered, then probably there's no additional risk at this point should you contract COVID.
Great. How about along the same lines, a person have scarring on their lung from radiation? Is that something to worry about?
Yeah, so scarring on the lungs is, we see that with in almost all patients to some degree who have radiation, but it's usually very focal. It's usually, the radiation oncologists are very careful, particularly these days with 3D conformational planning. They're very careful to minimize the exposure to the lungs from radiation, and so on our patients who we need to get CAT scans on, we'll often see sort of just at the border, the surface of the lung, a little bit of an area of radiation scarring. In general, we don't think, unless you've had fulminant, radiation pneumonitis in the past or going through that, which is honestly incredibly rare in breast cancer patients. We generally don't think of long-term effects of radiation of having any negative impact on your risk of complications from COVID. And I certainly wouldn't use that as a worry to decline radiation.
Yeah. Going to follow-up visits and going back to work, a few questions, but coming back to that theme. One question is from a person who says, I was recently tested negative, I assume for COVID, but told I need a second negative test prior to my radonc OV. Is there a recommendation for testing prior to routine follow-up visits?
Yeah, so this is in the early days of the pandemic at our hospital, these testing requirements were literally changing every day as we learned more and we understood more and we're developing policies. The short answer is each hospital, each outpatient facility is going to have their own requirements and recommendations. In general terms, what I can tell you that seems to be emerging, and I should say some places are requiring temperature screening when you walk in the door. Other centers are just calling the day before or screening when you show up with a verbal questionnaire. A general approach is if you're doing testing, if you have no symptoms and they're requiring you to have testing, honestly, that's a little unusual. So the fact that they were doing testing makes me wonder if you were having some symptoms that requested that. But if the symptoms have resolved, a common approach and a version of this sort of that our hospital is doing is if you have the symptoms resolved and you have a negative test, then 24 hours later you're cleared and can go back. For a while it was 72 hours with no symptoms. If you're still having symptoms, then a second test actually might be required because you haven't had symptom resolution, and so there can be false negatives on these tests. And I should say that's one of the things that people should be aware of. If you happen to be getting a nasopharyngeal swab, you should make sure that it's done correctly. I've seen a lot of these stories on the news where it's kind of in their B-roll footage in the background, they're showing testing and they're doing it wrong. If you're just going up into your nose, that's not the right way. It should really be going straight back. You should feel them sort of tickling the back of your throat, kind of what it feels like if you kind of swallow soda and the carbonation goes to the very back of your throat. That's what it should feel like. If they're not going back that far, then a negative test is really just an ineffective test. And so for this patient asking the question, it really depends on the policies of the outpatient facility, whether you're having symptoms now, whether you had symptoms, and so it's not a universal answer for outpatient visits.
Okay.
I will say at our center and many centers, we do have workflows and pathways that we are still treating patients who need radiation or chemotherapy who do test positive. We have very clean workflows now where those patients are essentially being escorted so they're not touching anything. Rooms are being cleaned, and so we do have the capability of caring for patients who are COVID positive and need their care, which doesn't sound like is this case, but again, it's up to the local center.
A couple quick questions, and then we'll kind of get to the closing. But Going back to work, two questions on those. One question is, could the 65 to 75-year-old population enter the workforce? And I assume in the context of a diagnosis of breast cancer.
Yeah, so again, I think if this is an older breast cancer, your breast cancer was a few years ago, you're 65 to 75 now, then I would follow the general guidelines that we're getting from the CDC and from your local healthcare team. And essentially, the short version of that is we're seeing infections happen across the board, age sort of independent. But the complications and hospitalizations do seem to be disproportionately higher in older populations. And I'm not saying old, but older. And so I wouldn't say being 65 to 75 means you can't go into the workforce, and certainly an older history of breast cancer shouldn't really weigh much at all. But you need to take into account your other, what we call comorbidities or other health problems, whether you have underlying asthma, whether you have any COPD, whether you have diabetes, or other problems that, should you get COVID, could be higher risk. But the breast cancer in and of itself, no. If you're in active treatment, then the same sort of things that I mentioned earlier applies, and the risk of immunosuppression, and I probably would wait until you're sort of recovered from your chemotherapy treatments.
Okay. And a last direct question is, any thoughts about a teacher going back to work in the fall? So a teacher, if that is an option with just recently 3 months being out of active treatment, the active treatment was capecitabine.
So I think if somebody is all done with their chemotherapy and are a few months out, in general, the residual immunosuppression that happens should be essentially resolved. There may be some lingering, again, minor immunosuppression, but not to the extent that I would worry about that in and of itself. My bigger worry is, again, for a patient like that would be outside of breast cancer, just is the school system where you work going to be able to maintain physical distancing of the students? Are they going to be screening students? Our family's going to be responsible that if somebody in the house is feeling ill, they'll make sure to communicate that and potentially hold the student back until things resolve. So I would say I would worry less about the breast cancer specific issue in a patient like that if they're done with their treatment after a few months, and just more about, in general, making sure that being back in the workforce is being done with sort of responsible behavior by all the other people you're working with.
Okay, thank you. Before concluding, I do want to end on one question, and also kind of give you an opportunity to also kind of end with any comment. Obviously, as the director of clinical research, I don't want to leave this webinar without asking about clinical trials. So any perspective in terms of, will it be harder for a patient to be involved with a clinical trial for breast cancer due to the pandemic within this year more broadly? Any thoughts on that? Any things you can share on that? And also, please, any broader comment you'd like to do before we conclude the webinar?
Sure. So the clinical trials world has been a real challenge across the country and world. At the beginning of this pandemic, we really did have to sort of, we never shut down 100%. Some cancer centers did. We were fortunate that we didn't have to shut down our clinical trials 100%. But we had a directive from the hospital, from our institutional review board, to really focus on those trials that had a significant likelihood of either helping to prolong someone's life or significantly alter the course of their disease. And so we really tried to restrict who we were accruing onto these trials for sort of those situations where we thought we had a better chance. And so some of the randomized placebo-controlled trials in early stage patients, we kind of put on the back burner a little bit. But we are now starting to open that up more. And again, our primary consideration during the pandemic was to make sure that we're adequately taking care of patients who are already enrolled on trials. With the staffing issues we've had, where we've had to do remote working for our clinical research staff, our priority was really taking care of those people on trials. But we are now, just like the workforce is reopening, we're encouraging accrual onto our trials, and we are definitely trying. Sorry, I'm getting an unstable internet connection. I'm not sure if I block out there, but We are definitely trying to modify things during the pandemic, and so we've done. Did I block out there?
Yeah, for a second.
We are trying to
Yes.
modify things so that we can do more remote visits. Okay. We're trying to modify things so we can do remote visits. We can ship drugs. We've been avoiding some EKGs or things that require more patient contact, but those are all coming back now. We recognize clinical trials are really incredibly important to our patients, and it's really a priority, I think, in our cancer center and most to get these fully back online.
Yeah, and just curious, if somebody has contracted COVID-19, has that been used at all as an exclusion criteria, or it's not coming up?
So it's interesting. So some studies have on the fly asked if we can do COVID screening. We are not finding that most sponsors are requiring testing, but we're already sort of screening patients, at least with questionnaires, before, and we're trying, and certainly if anybody tests positive, we're letting the sponsor know and reporting that in our adverse event reporting. I would expect that all new trials coming through, that the sponsors are probably going to have that, that if there's sort of known COVID positivity, that they defer enrollment until that's cleared. The good news is we're seeing most patients really do recover from COVID infections, and usually within 3 or 4 weeks. And so if there's a delay of getting onto a trial because of COVID, hopefully it's a relatively short-term delay.
Great, thank you. First of all, I do want to thank you. So we should wrap up. Any last comments on your side, Doctor, before I just kind of, tee it up and close the webinar? Oh, maybe you didn't hear me.
The only comments I would make is to, first of all, no, I heard you. Can you hear me?
Yes, we can hear you.
Maya, can you hear me?
Yes, we can hear you.
Okay.
Yeah.
Sorry, I tell you, I have a good signal, but the only comments I would make is, okay, the only comments I would make are, we are not likely to see the end of infections for quite a while, and but we want to get people back to trying to do the things that they like to do. So really, just try and focus on practicing those physical distancing and other routines that can really help protect you from getting an infection. Yeah, that's it. So thank you for including me in this.
Great. Well, thank you so much. So first and foremost, I do want to thank you, Dr. Isakoff, for taking the time with us. This has been very, very helpful to all of us. I do want to also thank everybody that have joined us today for joining us. If you have any follow-up questions or thoughts, please email us, covid19@outcomes4me.com. We will be sending out a survey after this for feedback on what you would like for future topics for webinars to cover. And we will also be making these videos available on our app with a blog recap if you want to revisit or share with others. Please make sure you don't miss out, you enable notifications on the Outcomes4Me app if you'd like us to let you know about future updates and future webinars. With that, I do want to thank you all. Thank you again, Dr. Isakoff, and stay safe.
Thank you.